Good afternoon, everyone. I'm Darun. I'm from the Yong School of Medicine in NUS. I'm from the Departments of Physiology and Medicine, and also associate member for the Center of Medical Education. It's my privilege and honor this afternoon to moderate this session. This is the prime session for the month of May, and a few brief words about PRIME. So PRIME stands for Priority Research in Medical Education, and it serves as a monthly platform for staff involved in medical and health professional education projects. It serves to present their ideas, proposals, research findings to a wider community, including educators and researchers, and receive feedback on their approach as well as their research. It is a monthly session, usually held on the first Monday of each month, from 12:30 p.m. to 1:30 p.m. Singapore time, unless specified otherwise. There are usually 2 sessions, and each presentation takes about 20 minutes each, and there will be a 10-minute Q&A at the end of each session. I'm now privileged to introduce our first speaker. Our first speaker is Professor Chien-Da from the Chang Memorial Hospital, Chang University College of Medicine in Taoyuan, Taiwan. He's a physician educator and chest physician with over 25 years in clinical education and specializes in medical education research and pulmonary medicine. He's a professor at Chang University and the chief of the Center for Faculty Development at the Chang Memorial Hospital, focusing on faculty development, narrative medicine, and clinical reasoning. We're in for a treat this afternoon as he presents his work on strengthening clinical teaching in postgraduate year training, a realist evaluation on faculty development, and ACGME core competencies. So may I invite Prof. Huang to basically start his presentation. Thank you.
Hi. At first, thank you, Professor Dong Long Ko, the introduction. I'm Chien-Da Huang. I'm from Chang Memorial Hospital, Chang Medical Education Research Center in Taiwan. I'm very happy and excited to be invited by the NUS-PRIME section to present my study. Today I will present my study. The topic is strengthening clinical teaching in PGY training, a release evaluation on faculty development and the HGME core competence. Next. I am the project's PI, Chien-Da Huang. I also have 4 important members, Dr. Zheng Changji, Dr. Lin Zhanyu, Dr. Huang Jixian, and my research assistant, Bita. Next. As you know, the clinical educator plays a very important role in shaping the next generation of physicians. They are responsible not only for deliver essential medical knowledge and skill, but also enhance learning for prepare for the real-world medical practice. However, being a good doctor does not mean he should be a good teacher. So this is why faculty development programs are so important. They can help improving teaching and adapt to the challenge of modern healthcare education. So finally, enhance both learning outcome and patient safety. Next. So in Taiwan, we have a faculty program for general medicine training. This slide presents the 14 plus 7-hour faculty development model. So the first component is a 7-hour seminar, as you can see in the left-hand side, which include a series of 45 mini sections combining lecture and the workshop. And it focuses on 6 ACGME core competencies and the related teaching skill. And more important is organized with our government to broaden our medical education in Taiwan. And the second part is consists of 14-hour of practice training. This including on-site coaching and the demonstration by faculty development instructor across various clinical settings, such as outpatient clinics, inpatient teaching work, and it also incorporated a lot of key education strategies like case-based discussion, EVM, OSCE, mini-6, and so on, teaching skill. And more important, medical humility, ethics, and holistic care training course was also incorporated. So the program is designed to build on foundational knowledge, hands-on teaching skill, and more importantly, holistic care training for general medicine. Next. As you know, the ACGME have 6 core important competencies. They are based on the physiology, psychology, and the society. And they also supported palliative care, long-term care, and cross-disciplinary practice. Next. However, how about the key challenge in evaluating a faculty development outcome? Traditional evaluation focuses only on outcome, asking did it work without exploring why. However, you know, the clinical education is complex and the context greatly influence success. So we need a serial-driven approach to uncover the mechanism behind the effective program. So really evaluation is a good solution, helping us understand not just whether faculty development work, but also how, why, for whom, and under what condition. So next, thank you. Next. So our research question is want to explore how faculty development program for general medicine, such kind of 40+7 program, impact the education outcome related to ACGME core competency. So we have 3 important objects. The first, we want to explore the context, influencing faculty teaching outcome. Secondly, to identify the mechanism explaining how faculty development work or fail in different settings. And third, we want to make the CMO configuration to the ACGME core competency. Next. So here are our method. Okay. So we use the release evaluation method with 4 steps. The first step is we involve a release synthesis to initiate program serial. A second, we include interview with faculty, designer, and the clinical teacher post-training. And the third, we analyze the phase 2 interview. And finally, step, we analyze interview and generate 9 new CMO. Next slide, please. And we use the release evaluation design. As you can see in the right-hand side slide, the CMO model including the context. The context is both condition influencing the intervention and the outcome assesses the result. And the more important is we want to uncover how the program driving change. It's a mechanism. So the key feature of this method include this is a serial-driven exploration of the program outcome, and this is focused on the CMO configuration. And finally, this kinds of evaluation include iterative analysis and serial refine. Next, our interview process, we interview 15 clinical teacher post-training, and the interview, we use a semi-structured one-to-one interview, each lasting about 6 minutes. either face-to-face or by way of technology assistance, such kinds of Google Map. And this process has three phases. The first phase is CDN grading to explore initial insight into program function. The second phase is a CDN refining, where a interview help adjust and sharpen emerging CMO series. And the third, CDN consultation with seven interviews, further supporting and refine our finding. Next. Our data analysis and CMO mapping, including three steps. First, we do coding on the data in Atlas version 25. And the second step is view CMO configuration by identify how contact trigger mechanism leading to the outcome. And the third, we make each CMO to the relevant ACGME core competency to align with the educational standard. Next, here's our result. Most of the participants are male, about 67%, and the position mostly are the lecture. The age mostly is from the 36 to 45. And about 14.6% participants have less than 5 years of teaching experience. Near half are related new teachers. Next. Here is the distribution of 15 participants based on their clinical specialty group. As you can see, the distribution illustrates the diversity of clinical background among the faculty participants, from the pediatric, internal medicine to the dermatology and oncology. Next. Here I will show the CMO result. And this slide focus on how institutional support through policy and incentive to enhance the faculty engagement and the teaching effectiveness in clinical setting. So we got two CMO in this domain. The first CMO, the context is institutional policy, and the mechanism is faculty engagement, and the outcome is competence development. And the HGME alignment is related to the patient care and the medical knowledge. And this CMO reflects how institutional structure and collaborative support foster a productive teaching environment. And the second CMO is CMO 9. The context is incentive and the recognition. And the mechanism is salary and the credit system. And finally, the outcome is the faculty motivation. And the outcome is related to the system-based practice. And this CMO reflects how institutional acknowledgement, especially through tangible reward, such kinds of salary and credit promotion, can help balance faculty workload and encourage consistent educational engagement. Next slide. And this slide talk about two important key CMO among on the skill enhancement. We got CMO2 and the CMO3. In CMO2, the context is senior mentorship. It means the presence of senior faculty who provide mentorship to a role model in both clinical and the education setting. So this lead to the mechanism of role model explosion. And the outcome is includes leadership growth. And related to the ACGME competency is including the interpersonal communication skill and the professionalism. And this CMO2 showing that the mentoring does not just transfer skill, but also foster motivation and a sense of responsibility to lead and teaching others. And the CMO3, the context is pedagogical again, and the mechanism is structural training, and the outcome is faculty competency. And the related to the ACGM core competency are practice-based learning and improvement. And this CMO3 reflect the value of faculty in bridging the gap between clinical expertise and the teaching proficiency. So some of the faculty have good clinical expertise, but they are not so good in teaching proficiency. So this gap, structural training is very important. Next slide. This slide also focus on another two important CMO. The first CMO is CMO4. The context is supported learning environment, and the mechanism is reflective practice and induce the outcome of engaged instruction. And the ACGME core competence reflective is practice-based learning and system-based practice. And this CMO4 reflect how reflective and experiment learning translate into more meaningful instruction and mentoring. And in CMO4, it's about the assessment. The context is standard assessment, and the mechanism is rubric adoption. And finally, the outcome is fair evaluation. And this highlight how the structural use of rubric build faculty confidence in evaluation, learner fair, and medical. So standardized assessment is very important. Next slide. And this next slide talk about the clinical pressure relative CMO. In this domain, we got two CMO. The first CMO is CMO5. The context is the faster patient and the high pressure clinical training environment. The mechanism is a stress adaptation, where faculty adjust their teaching approach to handle emergency crisis. And the outcome is crisis management ability increase. And this result highlight the low modeling and the experience sharing under pressures as a powerful teaching method. And the CMO is a time construct context. And the mechanism is target teaching. And finally is competency development. This reflects how faculty balance clinical obligation with educational commitment, making each moment count under time pressure. And the relative HGM competency is problem-based learning improvement and the medical knowledge. Next. So next is our final barrier about the CMO. The barrier inhibits the problem-based learning improvement and also communication skill. And the context is disusability. As we know, we always use digital platform within the faculty development to trigger the emergence of feedback. However, some of the digital maybe get the poor usability and the technical issue. This barrier make difficult for faculty member to provide timely and effective feedback. So we should be careful. This kinds of CMO can increase workload for the teachers, naturally affect their quantity of feedback. So this result showing that even when digital tools are available and very popular now, if they are not user-friendly or well integrated, they can become obstacle rather than enable in teaching and the competency competence. So we identify the barrier. Next, so we make three key component inclusion in our study. First is we showing the program can enhance clinical teaching competency. Such kinds of role model, exposure structure training, and the reflect practice and the significant improve the clinical teacher's ability to develop PGY's HGM competence. Second, context matter for mechanism activation. Such kinds of institution policy, incentive, clinical pressure, and the digital tool mechanism influence mechanism like faculty engagement, stress adaptation, and the target teaching impact outcome. And finally, we identify barrier and also identify enable. The barrier it's about the high pressure environment and the poor digital usability. However, INAMO, including the senior mentorship, supporting learning environment, and the standardized assessment, emerge as a strong enable for educational improvement. So no matter barrier or enable can give us a lot of very reflection. Next. So finally, I talk about my study strengths and the limitation. We have 4 strengths. This is a student-driven approach. And we got a lot of rich quality data from the in-depth interview. And the release evaluation is based on alternative analysis. So we can get a lot of very deep information. And more important, our outcome is correlated with the HGME, and we mapping with the HGME. However, we have 3 limitations. This is a small participant. I mean, initially we are planning for 14, but potentially now we have 15 participants. And the second, sometimes the senior development phase have overlap, so which makes not very clear for clarification. And finally, this is a Taiwanese context, so we need to adaptation before applying elsewhere. Thank you very much for your listening.
Thank you very much for sharing that wonderful work, Prof. Huang. This paper and this presentation is open to questions. So can you, for the audience, can you put the questions in the chat, and Professor Huang will address those questions for you. I think in the meantime, while everybody's waiting, can I ask Prof. Huang? This is a very interesting method, way what we call realist evaluation. How did you come about getting into this realist evaluation to apply it to your evaluation of faculty development? Did you have any special moments whereby it was revealed to you to use this methodology?
Yes, very good question. Yes, real evaluation is based on the CMO, means context, mechanism, and the outcome. So it is very suitable for any kinds of medical education issue, because you know the medical education is complex. So there are some relative context, even they have different mechanism. So you can be used to evaluation the outcome and also under the context. And then we use the CDR-driven approach. More important, we want to uncover the mechanism. So the key issue is the mechanism issue. So I think every kind of education issue can be applied, but more important is you should be carefully about the definitions of outcome. Sometimes, so research question is very important to make it more clear about what you want to see the outcome, and then you can trace back to the mechanism. This is my opinion. Yeah.
Right. So yeah, it's a fascinating. This is the first time I've come across it as well. It's fascinating. There are a couple of questions here. What are some strategies in place to address the barriers that you raised, for one? I think at the end, you did a part of
yes, yeah. Okay.
So I
we
think
identify. Yeah, very good. We identify most of the CMOs are good, but we identify two more negative feedback is a high pressure learning environment, and the second is about the digital unusability. But in the high pressure clinical environment, because as you can see, although the outcome may be increased workload, but our mechanism is a strict adaptation. So it's not very variant because we have solution to salute the high pressure environment uses the strict adaptation. So it's not a very, but more important is the digital usability. Maybe it's a Taiwanese context. Currently in Taiwan, each medical center to introduce their own digital platform. Some are very good, some are very user-friendly, but some of the platform, especially on assessment. Currently, Taiwan was promotion for the CGMERC. Some of the assessment is not very integrative or not user-friendly. So this is why our faculty, when we interview them, they are very complain some of the digital platform. So this is very tricky and very interesting. Maybe not every country has this kind of problem, but currently in Taiwan, we face the digital usability in my study.
Yeah. It's the same question I'd like to ask, but frame in a different way. Your digital usability, because these are real world practice, right? So would the digital usability also include things like the electronic medical records that are different across different hospitals and those kind of things, whereby it can be, again, an increase in cognitive load trying to get used to different system in different health systems.
Yes.
Yeah, so that can also add on to the so-called barriers, especially in clinical training. Are there any more questions? Because I think we need to pass on to the next segment. If not, it just leaves me to thank Prof. Huang for a very interesting lecture. We look forward to again more information subsequently, or especially since you identified the mechanisms. I think all of us are really interested in, after knowing that, whether some of the solutions you put in place will be really critical in taking faculty development forward, since you've been working in this area for many years. So thank you once again for sharing your work with us.
Thank you for your invitation.